Welcome, everyone, to another episode of Plum Peeps. We are extremely excited to have our second Plum Peeps in the ATS Clinical Problems Assembly collaboration. Today, we are bringing you the first episode of our COPD series and are joined by two amazing obstructive lung disease experts. But before we introduce our guests, I want to check in with the other half of Plum Peeps. Furf, how's it going?
Monty, I'm doing great. This is like my treat of the week, always getting to record these episodes and to learn some things. I know our listeners encounter COPD all the time, inpatient and outpatient, throughout their training. This is a diagnosis that a lot of patients unfortunately have and that we're all dealing with. So learning the foundations of COPD classification and management from these experts is going to be incredible for me and for everyone listening, I hope.
Absolutely, Furf. I look forward to a great discussion today, and let's get started with introducing our guest.
Great. So first we have Dr. Bob Weiss. Bob is a professor of medicine at Johns Hopkins School of Medicine, and he served as the medical director of the Pulmonary Function Lab at Johns Hopkins Asthma and Allergy Center. He is a leader in the care of patients with obstructive lung disease, and his research focus has been conducting multi-center clinical trials in airways disease, and he's also a master physiologist. He's also been involved in various capacities with ATS throughout his career, and he received the ATS Clinical Problems Assembly Lifetime Achievement Award in COPD. Welcome to Palm Peeps, Bob.
Thanks so much. It's a great pleasure to be here today.
Of course, we're glad to have you on, Bob. And I still remember my first year as a clinical fellow early in July when you taught us how to interpret PFT. So I still remember some of your pearls from that. So next, we'd like to introduce Dr. Wassim Labaki. Wassim is an assistant professor of medicine in the Division of Pulmonary and Critical Care, as well as the medical director of the Lung Volume Reduction Surgery Program at the University of Michigan. Wassim's clinical and research interests span the history, the epidemiology, as well as the role of biomarkers and metabolomics in COPD. Wassim was a recipient of the Early Career Investigator Award in COPD from the ATS in 2019 and is currently on the program committee of the ATS Clinical Problems Assembly. It's a pleasure to have you on today, Wassim.
Yeah, Christina and Dave, thank you for having me. Pleasure to be here and looking forward to discussing COPD.
Great. Us too. And before we dive in, just as our standard disclaimer, this podcast is not meant to be used for specific medical advice, and our views today are not reflected of our respective employers. We have some mini cases, and all the data we'll present is HIPAA compliant with details changed to protect everybody's privacy.
Thanks, Dave. I'm so excited for our discussion with Bob and Wassim, and I know we have so many questions for them. But before we start the discussion, I wanted to present a common patient scenario so listeners can go back to it during the discussion and kind of have a framework in their mind as we're talking through some of the questions. We have a 60-year-old woman with a history of active tobacco use as well as hypertension who was diagnosed with COPD 3 years ago. Her post-bronchodilator FEV1 to FEC ratio is 0.55, and her FEV1% predicted is 58%. She describes having a chronic cough and gets short of breath when walking uphill, which she primarily notices when she's walking to catch her metro stop to work. Her COPD assessment test or CAT score is 9. She's been hospitalized once in the last year for treatment of an acute COPD exacerbation. She is not currently on maintenance therapies but uses a rescue inhaler as needed. So before we discuss the severity of her disease and approaches to management, Wassim, can you briefly describe for our listeners today how you define COPD? And are there any common guidelines that you refer to?
Yeah, so I refer to the GOLD 2022 guidelines, and GOLD stands for the Global Initiative for Chronic Obstructive Lung Disease, and it is an international panel of experts that meet on a regular basis. And this panel reviews the literature on an ongoing basis to issue these guidelines on the prevention and management of COPD. Now, GOLD recommends to define COPD using 3 criteria. You must have these 3 criteria: the presence of symptoms, the presence of risk factors, and the presence of airflow obstruction. So let's go through them one by one. So as far as symptoms go, these are, general respiratory symptoms, typically shortness of breath, cough, mucus production in patients, with COPD. And we'll talk more about symptoms later on, but it's very important to know how to elicit symptoms from patients when asking questions during the history part. Because if you're to just ask someone if they are short of breath, some patients with COPD may say that they are not short of breath. This is because consciously or unconsciously, they would limit their physical activity to avoid the uncomfortable feeling of shortness of breath. Rather, going with open-ended questions such as, how far can you walk before you get short of breath, or how many flights of stairs can you go up, or what are some activities in your daily life that you are not able to do because of your shortness of breath. You may get a better sense of one, whether they have symptoms, and two, how severe their symptoms are. And like I said, in addition to shortness of breath, it's very important to ask about other respiratory symptoms, specifically cough and mucus production, which are common in patients with COPD. Now, for the number 2 criterion, which is the presence of risk factors. So, smoking is the most common risk factor, for COPD. That being said, it is not the only risk factors, and many patients who never smoked can develop COPD. And it is estimated that up to 20% of COPD is not related to smoking. So, what are some of these risk factors? For example, occupational exposures, right? Like exposures to dust, fumes, gases, chemicals in the workplace, especially when significant and especially when prolonged over years, can result in airflow obstruction and COPD. Another risk factor would be exposure to biomass fuel from cooking and heating. For example, in many developing countries and in some areas of developed countries, people rely on wood and coal for cooking and heating. And when used in the confined environment of the house, this heating generate fumes that concentrate, in the internal space and eventually cause injury to the airways and the lungs over years. And also things like recurrent respiratory infections in childhood or uncontrolled asthma in childhood or early adulthood can lead to COPD. So that these are all important factors to keep in mind. And for the number 3 criterion to diagnose COPD, airflow obstruction, it is defined as a post-bronchodilator. Again, post-bronchodilator, FEV1 over FVC less than 0.7 as an indication of a fixed airflow obstruction. So using these 3 criteria, which are relatively simple, one can diagnose COPD, and you need to meet all 3 criteria.
Thanks so much, Wassim. That was a great review. And I really always love those criteria because I feel like they hone in on a disease process so well. Like there's this epidemiology or the pathophysiology of the risk factors, and then the symptoms, this clinical correlation, and then some objective data. And so I just love it's a simple system that really captures it well. So now that we have a broad definition of COPD, we have a couple more questions for both of you. So Bob, we just heard that in terms of the criteria for diagnosis, we're looking at post-bronchodilator obstruction. But I'm curious if you can talk to us about how we further use the obstruction and PFTs to help characterize the severity of lung function impairment. I know that we're often looking at FEV1 after we've diagnosed that they do have some obstruction there.
Sure, that's a good question. The important thing to understand is that the ratio which we use to diagnose airflow obstruction, meaning that it takes too long to blow the gas out of the lung, is not very well correlated with the symptoms and mortality from COPD. That is much better correlated with the level of FEV1, either the absolute level or the percent of predicted. So after one makes a diagnosis of COPD, the next thing is to grade the severity of the disease. And that's based on the FEV1 percent of predicted. Um, People who have an FEV1 percent of predicted less than 50% are considered to have severe COPD, and less than 30% of predicted are graded to have very severe COPD. Between 50 and 80%, that's considered moderate. That's like our patient today. And above 80% is considered to be mild COPD. So that's useful both in determining the treatment, the prognosis, and what the approach to the patient is going to be overall.
That's great. And I want to stick with the PFTs for a little bit because it's such an important part of what we do in our diagnosis. And I know you're an expert, so I like to sort of pick your brain. I think different labs are using different interpretation systems now. I know there's some standards out there too. The old, just a raw value of zero point 0.7 being used less commonly, and some people now looking at the lower limit of normal or using confidence intervals. And I was wondering if you could just comment on that and how it plays a role in diagnosing patients with obstruction.
Yeah, this has been a long-standing controversy amongst pulmonologists, and I think become such a controversy because it's so unimportant in the long run. It turns out that an average lower limit of normal for, say, a middle-aged man is very close to zero point 0.7. And that's when the disease presents. And so it's a very simple way of determining whether there's airflow obstruction or not. It's very easy to remember that. Okay, and it does actually correspond very well throughout a long age span with symptoms and outcomes. In fact, a recent study looking for a sort of the ideal threshold found that it was about 71% that we should use. So, although that zero point 0.7 sounds simple, we've used it for a long time, it is important. It's also important to understand that virtually every clinical trial of any drug that's been approved by the FDA has used that as the threshold, not the lower limit of normal. Now, the argument for the lower limit of normal, which cuts off the lowest fifth percentile of a population, um, is that as we age, we tend to lose the FEV1 FVC ratio. It gets lower, so that an 80 or an 85-year-old individual could have an FEV1 FVC ratio of zero point 0.7 and still be well within the normal population for that age. The real debate is whether that aging process, which induces airflow limitation, is physiologic or whether it's pathologic. But for the practitioner, I believe carrying around the number of 70% is so much easier than carrying around a computer to calculate the lower limit of normal that it's just what we should be doing.
Yeah, that's great. And it also builds on Wasim's point that, the diagnosis is not just one number, it requires three different things to do it. So it's not as if it's becomes a holy grail of the diagnosis. So my final sort of PFT question, or we can always dive back into, there's more to PFTs than spirometry, of course. And I'm curious what values on lung volumes and gas transfer you think are the most important for our patients that we know have COPD, in addition to grading the severity of their obstruction.
Yeah, so I think that every patient who is newly diagnosed with COPD deserves to have a complete set of pulmonary function tests at the outset. And this would include not only spirometry before and after a bronchodilator, but also lung volumes and a diffusing capacity. The lung volumes can be done either with a gas dilution method like helium or by body plethysmography, because both of those will give an idea of whether there's hyperinflation of the lung, namely an elevated total lung capacity, which is a hallmark of emphysema, or whether there's air trapping, gas trapping, which is an elevated residual volume, which is the hallmark of small airways disease. The other important thing, and perhaps the most important reason to do lung volumes, is to investigate for other lung diseases that might cause a combined restrictive and obstructive defect, such as can occur commonly with sarcoid, can occur with combined pulmonary fibrosis and emphysema, with obesity, and the like. So the lung volumes are important. The diffusing capacity is important for several reasons. First of all, a low diffusing capacity coupled with hyperinflation is a very excellent indicator that emphysema is the culprit and the cause of the airflow obstruction. The diffusing capacity tends to be more normal in patients who have mainly airway disease like chronic bronchitis. And in asthma, it's the diffusing capacity is even elevated. So it's a great way to tell the difference between asthma and COPD. The other utility of the diffusing capacity is that it can tell you a lot about whether a patient is likely to need oxygen or whether they desaturate with exercise. When the diffusing capacity is below 50% of predicted or so, about half those patients will desaturate when they exert themselves. And when it's above 60%, then it's not necessary uh, to check the patient for exercise desaturation unless they have some intercurrent illness. So I like to get lung volumes and diffusing capacity along with spirometry in a newly diagnosed patient.
I don't know that I've ever had a short speech about lung volumes and DLCO with more pearls than the one that you just gave me. That was unbelievable. That was great.
Totally agree, for thank you so much for that, Bob. And going back to our patient, I think we can further characterize her having an FEV1% predicted of 58%, as you mentioned, Bob, as her having moderate lung function impairment, which would be consistent with the GOLD stage 2. She did have a full set of PFTs, but did not have any evidence of hyperinflation or air trapping, and her DLCO was 59% predicted, so compatible with a moderate gas transfer defect. I want to go back to you, Wassim. If you're seeing this patient for the first time clinic, what other diagnostic tests would you consider obtaining for her?
To build up on what Bob just said, for example, you consider, should I get imaging? In this patient, for example, given that she does not have evidence of hyperinflation or air trapping, and her DLCO is decreased, but not significantly decreased as it stands at 59% of predicted, I would not necessarily consider imaging to look for emphysema, because the extent of any emphysema she may have would be minimal to mild at most. However, you could, as far as imaging goes, you could see if she's a candidate for lung cancer screening. If she meets criteria for lung cancer screening, and in that case, you would get a low-dose chest CT after discussing the risks and benefits of screening with this patient. In terms of additional workup, things I think about is a 6-minute walk test, which I would not do in this patient given her DLCO above 50% predicted. Another thing that one can look at is also the oximetry at rest that we frequently collect, in the outpatient setting, just seeing what her oxygen saturation is, at rest, just when collected in the clinic. I mean, if it is in the low 90s, let's say, or high 80s at rest, then she's likely to experience desaturation with exertion, in which case, a 6-minute walk test would be indicated. But not in her case. Something else I would think about is obtaining an EBG in patients with more severe COPD. I mean, typically, if the FEV1 is less than 50% predicted, and what I would be looking at is seeing if there is evidence of chronic hypercarbic respiratory failure, which can happen in later stages of COPD. This does not apply to this patient per se, but something to think about. A couple of things I would get is in alpha-1 antitrypsin deficiency, phenotype and level. In fact, the World Health Organization and the Alpha-1 Foundation recommend, obtaining an alpha-1 antitrypsin level and phenotype on all patients with COPD, even though the patients may not be your typical patients with alpha-1 antitrypsin deficiency, meaning someone in their 40s who has panlobular emphysema in the bases. Because sometimes the diagnosis is missed and can be diagnosed later in life, let's say when someone is in their 60s. And also, even though the classic imaging presentation is panlobular emphysema in the bases, this is not always the case, because someone can have panlobular emphysema in the bases because of their alpha-1 antitrypsin deficiency, but also have centrilobular emphysema in the apices because of some smoking history. And then when you look at the CAT scan, it would look more like diffuse emphysema, yet they do have alpha-1 antitrypsin deficiency. So I would get, the alpha-1 antitrypsin level and phenotype on her. And another thing I would get on her is a neosinophil level, as it may guide treatment down the road. Now, sometimes this is already available in the chart, because CBCs with differential are frequently ordered in the outpatient or inpatient setting for a variety of reasons, but something I would consider getting.
Thanks so much, Wassim. Yeah, and I think really the peripheral eosinophil count is as you mentioned likely available, but really something that I started to notice over the last few years as being more useful as far as treatment for COPD. So I think that's an important thing to look at. And Bob, anything else you'd like to add for initial diagnostic approach, or anything that you do slightly different than what Wassim's recommending?
Yeah, well, I think the issue of alpha 1 antitrypsin deficiency screening is a little nuanced, okay? The World Health Organization does recommend it in everyone with COPD if they have Northern European ancestry, okay? So it becomes a little difficult to know in exactly which patients we should really be doing it. Also, the patients who are the best candidates for alpha 1 replacement are those that have moderate abnormalities of lung function. So, if someone has severe COPD, then you're not likely to put them on replacement therapy. And screening might help with genetic counseling of the children, but usually those folks are so old their children are already have had their children. So it doesn't come up. So even though alpha 1 screening is very easy to do nowadays with a buccal swab or a finger stick, I don't think it's for everybody, but it does require a little bit of judgment. I think Wassim is right about the lung cancer screening to get CT, and that can provide very useful information because our COPD patients are at very high risk for developing lung cancer, and particularly in someone like this who can undergo resectional lung surgery, they're really an ideal candidate. It gets to be a little bit more nuanced in the patient with severe, long-standing COPD who would not be a candidate for surgery, whether they should have regular screening or not, and bears a discussion.
Thanks so much, Bob. I think those are really important points for all of us to consider. And as far as our patient, right, I think we're all thinking we want to make sure she has the correct diagnosis of COPD. And what we know so far is that it seems to be consistent with that. She has a fixed airflow obstruction on PFTs. She has a significant tobacco history, greater than a 30-pack year history. She has been diagnosed in her late 50s, and she has symptoms, as Wassim mentioned, are important to think about: chronic cough as well as dyspnea with exertion. I know that we've discussed a lot of important data for her, and I think those that may be listening, are now kind of wondering, how do we put it all together to determine her COPD severity assessment or classification? And Wassim, I wanted to see if you could walk us through the criteria you use to determine severity in COPD for those of us listening today.
Yeah, so when we talk about severity, it's important to be specific what we're talking about. For example, if we're looking at the FEV1, and this has already been covered by Bob, we are talking about the gold grade, as 1, 2, 3, or 4, where, an FEV1 greater than 80%, greater than or equal to 80% is, grade 1, 50 to 80% is grade 2, 30 to 50% is grade 3, and less than 30% is grade 4. This is the grade. But in terms of staging, and the staging guides therapy, and I'm talking here about A, B, C, D staging, we use a different set of criteria, specifically the burden of respiratory symptoms and the frequency of exacerbations. That's it, 2 criteria. And you can easily obtain these criteria just from listening to the patient and talking to the patient in clinic. So as far as symptoms go, there are 2 commonly used scales to quantify these symptoms: the MMRC and the CAT. So MMRC stands for the Modified Medical Research Council Dyspnea Scale. And this scale ranges from 0 to 4, with 0 being the best and 4 being the worst. And just to give you a sense of what the scale entails. For example, 0 would be breathlessness only with strenuous exercise. 1 would be breathlessness when walking up a slight hill, such is the case with our patient who becomes breathless when walking up to her metro station. An MMRC score of 2 would be shortness of breath when walking on level ground, but walking slower than other people of the same age on level ground. MMRC grade of 3 would be dyspnea after walking a few minutes on level ground for about 100 yards, and MMRC grade of 4 would be too breathless to leave the house or to dress, for example. So the scale regions from 0 to 4, with 2 or more being considered clinically significant and indicating a higher burden of dyspnea. So this is for MMRC. Now for CAT stands for the COPD assessment test. And as opposed to MMRC, CAT evaluates 8 different symptom domains, not just dyspnea, but it also looks at symptoms like cough, mucus, chest tightness, limitations doing activities at home, confidence leaving the home despite of the lung condition, sleep quality, and energy level. So a total of 8 symptom domains. Each domain is scored on a scale of 0 to 5, with 0 being the best and 5 being the worst. And the CAT can range from 0 to 40, with a score of 10 or more being considered clinically significant and reflecting a higher burden of symptoms. So using these criteria, you can classify someone with COPD as being less symptomatic or more symptomatic. You can use either the MMRC or the CAT. They are easy to administer. I know the CAT is like 8 questions, but I administer it to all my patients, when I see them in clinic. And it really takes less than a minute when you go through it question by question. So this is as far as symptoms are concerned. Now, the second question to ask is exacerbations. And the question is to ask the patient is, how many exacerbations have you experienced during the past year where you needed treatment with antibiotics or steroids? Now, some patients may not understand the word exacerbations. They may understand the word flare-up, or they may understand it as a description of increase in their baseline shortness of breath, cough, or mucus production beyond their normal, day-to-day variation. And did they receive, antibiotics or oral or IV steroids for this exacerbation? So the question is, how many of them have they had in the past year? And of these, how many have led to a hospital admission specifically? Now, if they only had 0 or 1 exacerbation in the past year, it would be a lower frequency of exacerbation. If they had 2 or more, or 1 or more in the past year, as long as this one specifically led to a hospital admission, this would count as a higher frequency of exacerbation. And using symptom and exacerbation information, you can classify the patients into A, B, C, and D for gold staging. So gold A would be low symptoms, low exacerbation. B would be high symptoms, low exacerbation. C would be low symptoms, high exacerbation. And D would be both high symptoms and high exacerbations. I mean, for our listeners, obviously, it would be easier if you look at it as a schematic, such as the one produced by the GOLD guidelines.
Yeah, and we'll definitely put that schematic up. It's a super helpful review, though, just really to get to the essence of it, that symptoms and exacerbations are what we care about. And the MMRC, I feel like, to be fair, I'm probably not as good as you. I probably don't do a CAT on all my COPD patients. And for our busy residents out there, with the MMRC, I did basically just incorporate those landmarks into my dyspnea questions that I ask people. Like, are you too dyspneic to leave the house? Can you go up a hill? And that way I sort of have an assessment of their dyspnea, just from kind of a general interview with them.
Yes, exactly. You can right away get a sense of where they fit on the MMRC scale just by asking them how their dyspnea affects their daily lives, And if they say, I get short of breath just with dressing, it's automatically a 4. And you can determine that right away. So going back to our patient here, the patient said that she gets dyspneic when hurrying uphill to get to the metro station. So this would be an MMRC of 1. and so a lower burden of symptoms. And she had one exacerbation during the past year that specifically led to a hospital admission. So this is, a higher risk of exacerbations. So in that case, she fits within gold stage C.
Thank you so much for walking us through that. Bob, I wanted to go to you for a follow-up question. You made the really insightful point earlier that we care about the gold grade, the level of FE1 decrement in terms of thinking about people's prognosis and their overall mortality. However, that's not in the ABCD severity system, which we're going to talk about is what we use to sort of guide our initial management. So I was just wondering if you could talk about that and comment on why that's not incorporated.
Yeah, so the reason is that it used to be incorporated, but it became very clear after a number of years of trying to develop this complex staging system that physicians treat symptoms and they treat exacerbations. And all of the research on clinical treatment of COPD medications has been based on patients with symptoms and exacerbation. So that's the reason for this ABCD classification. I want to point out, however, that GOLD uses this classification for the initial grading or staging of COPD, and that after one has initiated therapy and followed the patient, this staging system may no longer apply to an individual patient.
Oh, that's important for everybody to remember. That's great to know. And we're going to talk. I think I really like everything that both of you guys say, but Bob, I really like how you keep referencing the trials because it is important for us to remember that these are where these medications are sort of validated and where we're getting our evidence from. So I'd like to just throw another question to both of you as experts in the field. We're talking about the symptom scores, we're talking about level of exacerbations, but are there other assessment tools, labs, things on imaging that questions you ask patient that you think are important to grade severity in your own mind beyond, a little more nuanced than the ABCD? Things that some people talk about are BODE index, other comorbidities, maybe some biomarkers, but just anything that you guys think is important for our listeners to think about when they're evaluating these patients.
Well, I think that one of the things, and perhaps one of the most important things in our COPD patients, is to assess them for and appropriately address comorbidities. Most of our COPD patients have comorbidities, uh, likely because of their smoking, including coronary disease, heart failure. They have a very high prevalence of depression and anxiety, both of which contribute to worse outcomes. So that's an important thing to assess. When I see a patient with COPD, rather than going through the full CAT score, although we have that initially on the electronic medical record, um, I use what has been called the SF2. I say, how are you doing and what are you doing? Okay, because you got to understand their symptoms, but also what their functional status is. And if you can establish those two things, you get a good picture of a patient with COPD in just a few minutes.
I like that. It's keeping it simple. That's always the best. Wassim, anything else to add?
Yeah, I cannot agree more with Bob about looking at the entire picture here, specifically as far as comorbidities are concerned, and including cardiac comorbidities. So, patients with COPD do have a high prevalence of coronary artery disease, of both systolic and diastolic heart failure, of pulmonary hypertension. For example, if the DLCO seems disproportionately low to, the FEV1, for example, it could indicate the presence of pulmonary hypertension, and definitely worth ordering an echocardiogram in that case to see how both the left and the right heart are functioning. along with comorbidities. Sleep disordered breathing or obstructive sleep apnea are also common in patients with COPD, and a sleep study can shed a lot of light into what's going on to their breathing and their sleeping patterns at night. And in terms of more general assessments as far as COPD is concerned, I will sometimes order some of the tests I mentioned earlier. Specifically, if someone has an FEV1 less than 50% predicted, has evidence of hyperinflation and air trapping on their lung volumes, and have a DLCO typically less than 50% predicted, and let's say they are on appropriate inhaler therapy but still symptomatic despite adherence with this therapy and completing pulmonary rehabilitation, the question becomes, would they be candidate for more advanced procedures such as lung volume reduction surgery or bronchoscopic lung volume reduction? And in that case, I would order an inspiratory and expiratory chest CT to better understand both the distribution and extent of their emphysema and small airways disease. For people with an FEV1, less than 50% predicted and a lower DLCO, again, I would consider obtaining an ABG to see if they have evidence of chronic hypercarbic respiratory failure, in which case chronic home non-invasive ventilation may be a good option for them, as it has been associated with better outcomes in these patients.
Thanks so much, Wassim. And just wanted to ask, I know that you've done some work kind of in biomarkers in COPD. Besides the peripheral blood eosinophil count that you mentioned, are there any other things? I know some will bring up whether there's any utility of checking inflammatory markers or neutrophil to lymphocyte ratio. I just wanted to get your thoughts on those tests.
Yeah, I personally do not check these markers on a regular basis. Now, I may look at them because, for example, a neutrophil to lymphocyte ratio may already be available from a CBC with differential, and a higher neutrophil to lymphocyte ratio, has been associated with a higher risk of exacerbation, for example. But obviously, when we interpret these cell counts, it always has to be put in a certain context. When were these drawn? Were they in the midst of an exacerbation, or is it during the normal state? If I'm looking at those when they were drawn historically before, but I do not specifically routinely check them or monitor them.
I think that's a really great point. I think for myself and for those listening, it's really important to remember the context of when they were drawn. You can't necessarily look back and try to make an assumption based on today without knowing what the context was. So that was great. And a follow-up question, not related but related, Wassim, is how do you think some of the newer technological advances, such as remote digital monitoring, can be used in assessment to identify those individuals at risk of potential decline from COPD?
Yeah, this is currently an area of high interest and of very active research. And there are a number of different tools, that have been looked at or are being assessed, and they fall under the umbrella of remote digital monitoring, but they can mean different things. For example, mobile applications asking patients to answer questions or to report symptoms, have been tested. As far as physiologic monitoring, there are a number of devices, that have been looked at that can monitor physiologic markers such as heart rate, respiratory rate, cough frequency, even temperature, for example. Other devices that have been looked at are electronic inhaler sensors, meaning tracking how frequently a patient uses their rescue inhaler, for example. And these were pretty much looked at to try to see if we can catch an exacerbation early or predict an exacerbation. Now, these have been tested in various studies, and they have their advantages and limitations. For example, the electronic inhaler sensor, it's not just the frequency of of which an inhaler is used, but it's also the pattern, right? Because there are some patients who use their rescue inhaler every morning, and it would be considered a rather higher frequency of inhaler use. But the question is, like, is there a new pattern, a different pattern that is triggering their use in a more frequent way, or a different way that is associated with subsequent COPD exacerbation. And obviously, this is also limited by patient adherence, how much a patient would use the rescue inhaler, for example. As far as these other devices that track physiologic parameters. You have to take into consideration how easy they are to use, how acceptable they are to the patient, because some of them, are attached to the torso or are there as an armband or wristband, and also how is this data collected? Where does the data go? Is it monitored live, by at a central station, and would it alarm the patient to call their provider if there is a physiologic parameter, for example, the respiratory rate above a certain threshold, and how would that change management? So a very exciting area, but a lot of unanswered questions, and not ready for a broad rollout. But the future will tell. What would be the best way to use such technologies.
It's really great to hear about the things that are coming down the pipeline. While we're covering basics, but also, you never want to ignore all these great, innovations that are coming. And I appreciate you also mentioning the advanced therapies. We're going to do a full episode on that, the endobronchial valves, LVRS. I think it's a really important component of care. So going back to our case and going back to basics for everybody, we had a great review of determining the severity now and all the tools that we can use. And now we're going to focus on sort of practical management of COPD. So Wassim already said this, but we're framing this patient as a 60-year-old woman with gold group C severity COPD, who is an active smoker. So Bob, wondering based on that assessment, how you would approach her initial management.
Yeah, so the initial management, according to the GOLD guidelines, would consist of a single bronchodilator of the long-acting muscarinic antagonist class, the LAMAs. The reason that this is the recommendation is that there are at least two large clinical trials that have shown that tiotropium, which is the canonical LAMA, is superior to both indacaterol and salmeterol, both LABAs, in terms of reducing exacerbation rates. And since this lady has little in the way of symptoms, we're looking for a treatment that will reduce and prevent exacerbations. One other thing I would say about this category C, which is a relatively uncommon category compared to categories B and D, which is where we clinicians spend most of our time, is that there seems to be a very high prevalence of coronary artery disease and cardiac death in these individuals. And so careful attention to cardiac comorbidities would also be warranted in this patient, regardless of other symptomatology. With any patient who newly presents with COPD, it's very important to consider the basic preventive elements. And in this lady, the number one element, which has flashing red lights, is that she's a continuing smoker. Okay. And this is an all too common problem. I don't know if you're going to do one of these episodes on smoking cessation, but I want to emphasize to our listeners that there have been in the last couple of years something of a sea change in our approach to smoking cessation, with much greater reliance on pharmacotherapy adjuncts, particularly varenicline. There's been a downgrading, according to the ATS guidelines now, on other adjuncts, but varenicline plus nicotine patches is considered an appropriate treatment. And even giving varenicline to patients who are not ready to quit smoking. We used to try to move them up the scale to have a readiness to quit and then prescribe varenicline. But now the guidance is to treat smoking as a chronic comorbidity, and you treat it with medicine. I mean, you have to obviously share this decision with the patient, but much more aggressive with smoking cessation in that way. The other preventive measures that one would take, of course, are to make sure that the individual is up on their vaccinations, flu shots, COVID shots, obviously, and a pneumococcal vaccination. In particular, our listeners should be aware of the new CDC guidelines for pneumococcal vaccination. There's been a whole fleet of new expanded dimension pneumococcal vaccinations, and some of them make the full vaccination status as simple as receiving one shot. So I would advise people to update themselves on that. And then finally, lifestyle changes, exercise, self directed exercise, and we may get into it a little more later, but pulmonary rehabilitation is a vastly underused modality and would be very important for someone like this who's presenting for the first time.
Thanks for going over all that. And yeah, so obviously smoking cessation has got to be in top of the list for anyone who's still smoking and coming in with this. I wanted to ask a follow-up about some of those boxes in the gold criteria that allow the practitioner a little bit more choice. You mentioned that we mostly are spending our time for group B and D. And for group B, the initial recommendation is for either a LAMA or a LABA. And I'm curious about how you make that decision and what you do in your practice.
Yeah, so this is again a controversial area. And the debate is not only between LABA versus LAMA, but also whether you should just start off with the combination as first line therapy. I think most people, myself included, if we're starting with monotherapy, would use just a LAMA because that it has a long-standing record of safety and efficacy. And although LABA monotherapy seems to be safe in patients with COPD, the idea of LABA monotherapy is somewhat tainted by that SMART trial, which showed an increased mortality rate in asthma with a long-acting beta agonist. So that's tended to make physicians wary of LABA monotherapy in COPD as sort of an overhang from the asthma experience. I think it's also reasonable to start a patient on a LABA LAMA as initial therapy. The idea being, or the argument being, that why use an inferior drug when you can use a better drug? LABA LAMAs have a great safety record. They are moderately more effective than either drug alone in terms of bronchodilation, quality of life, and reduction of exacerbations. So I think it would be reasonable, depending on how often you would be seeing the patient and what their preference is, to start on a combination therapy.
Yeah, if one is good, two is better. No, not always, but I but I totally, that's sort of the way I go with my patients as well now too. If I can get them feeling better quickly.
Thanks, Bob. And I love that that you're getting all the controversial questions, and we're saving them from Wassim. But Wassim, I want to spend a little bit of time, talking about the box D that Bob alluded to, because it seems like there's even more options to consider, including inhaled corticosteroids. And wanted to see, Wassim, what kind of general framework do you use when considering to start an inhaled corticosteroid or ICS for your patients with grade D severity? Do you ever start ICS monotherapy, or do you always prescribe it as a combination therapy?
Yeah, that's a great question. And just to remind our listeners, so grade D, gold, or stage, I should say, gold stage D, refers to patients with a high burden of symptoms, and a high frequency of exacerbations. So for gold stage D, gold gives you options, either a LAMA and a LABA, or a LABA and ICS. And all these options are reasonable. But the way I think about it is I look at the specific situation that the patient is facing. For example, let's say they are very symptomatic, not only having a CAT score greater than 10, but having a CAT score of 20 or more. I would go straight to the LABA plus LAMA to provide this dual long-acting bronchodilation, on acting on the beta receptors, agonist on the beta receptor, and blocking the muscarinic receptors and providing that dual long-acting bronchodilation, which would be particularly beneficial in these very symptomatic patients. Again, CAT score of 20 or higher, or severe exertional dyspnea, typically an MMRC score of 3 or 4. As far as ICS is concerned, I do not prescribe it as a monotherapy in COPD specifically. I always prescribe it in combination in patients with gold stage D. And I specifically prescribe it for two categories of patients. Patients with a high blood eosinophil count, typically defined as an absolute eosinophil level of 0.3, or 300, depending on the unit you're looking at, or patients with the asthma COPD overlap. Because inhaled corticosteroids are first line therapy in asthma. And if these patients happen to have coexisting asthma on top of their COPD, NICS would definitely be indicated there, in conjunction with the LABA. So this is how I would think about it when I have someone with COPD gold stage D, and really try to personalize the therapy I initially prescribe to meet their needs and their clinical situation.
That's really helpful. And to follow up on that, Bob and Wassim, to comment, I think a lot of people will get patients who are on triple therapy for COPD. I think they, through hospitalization or primary care, they that's just what they're on now. And especially with Allergy or the combined inhaler being out now, I think even more common. So just hoping you could comment on the potential benefits of being on triple therapy, but also the pitfalls that everyone should be aware of.
Yeah, so there's little question, I think, that triple therapy, in terms of exacerbations, is better than either LABA, LAMA, or ICS LABA. However, in individual patients, the inhaled corticosteroid seems to add little. Those patients, as Wassim suggested, and also cigarette smokers, for a variety of reasons, seem to be resistant to inhaled corticosteroids. Now, for most people, inhaled corticosteroids are quite safe. Okay, but there are certain situations where you might want to discontinue them, particularly in a patient who's not likely to benefit from them. And that would be in individuals who have repeated episodes of thrush, and it can't be controlled with gargling and mouthwashing. In individuals who have had pneumonia. Inhaled corticosteroids do lead to a increase in pneumonia. Often that's small in terms of the benefit in terms of exacerbations, but still, I think it's prudent to avoid it in them to the extent you can in patients with recurrent episodes of pneumonia. And then finally, there are symptoms that can be just bothersome to people, and that includes atrophy of the vocal cords, chronic hoarseness, which can be distressing to some people, and also easy skin bruisability, which is discomforting to many people. So those would be the reasons for discontinuing or not starting inhaled corticosteroids.
This has been enormously helpful. And I think the last topic that we're going to mainly touch on today is thinking about patients who are Gold D, they're on their triple therapy now, and they're still having either significant symptoms or ongoing exacerbations. And we're going to have another episode talking about sort of advanced therapies, but I know there are other medical therapies that come up for these patients, specifically standing chronic azithromycin or roflumilast. And I was hoping, Bob, that you could talk us through when you determine a patient should get those. And Wassim, of course, anything to add would be helpful as well.
Well, I think you can make the case that any patient who is hospitalized for a COPD exacerbation should be placed on chronic azithromycin or roflumilast. We don't really know which of those two is superior. They seem to have very comparable benefits in terms of reducing exacerbations. Right now, there's an ongoing study called the Reliance trial that is testing this hypothesis. So hopefully, in a couple years, we'll know whether azithromycin and roflumilast or roflumilast which one is better. Obviously, the advantages of azithromycin is that it's readily available, it's inexpensive, toxicity seems to be low, but it does increase the number of resistant organisms. And antibiotic stewards would suggest that chronic antibiotic therapy should be avoided. Roflumilast, on the other hand, is not quite as well tolerated, but if you start with a low dose and increase the dose after a few weeks of half dose treatment, it seems to be very well tolerated. It's considerably more expensive than azithromycin and consequently is not on all patients' formularies. So that's a limitation. But I think either of those therapies should be considered in patients who have exacerbations. The other thing to think of in patients who've been hospitalized with exacerbations is to give them what we call a rescue pack at home. Give them a prescription for prednisone 40 milligrams for 5 days and a prescription for azithromycin or some other similar antibiotic. And if they're the right patients, they can start it in the first day or two of an exacerbation. And I always ask the patients to give us a call and let us know if they've started it so we can follow up with them. But that keeps people out of the hospital, which is one of our big goals these days.
And we see one quick follow up. The other thing that comes up sometimes, and there are some studies out there. So I've gotten questions from residents before about N-acetylcysteine for COPD exacerbations or prevention. Is that anything that you use, or something that we sort of gone by the wayside?
Yeah, there is some data there supporting the use of acetylcysteine. I think it was one study, some time ago, maybe 10 or 15 years ago, that did show some benefit. Although the benefit was rather mild, and it didn't really gain traction. I don't prescribe it on a regular basis, but I think about it, keep it in my back pocket for very select patients here and there, but this is not something I routinely prescribe.
Great. This has been such a fantastic last hour that we spent together, and such great discussion, and so many pearls that I know many will be re-listening to from both Wassim and Bob today. I think after today, Dave and I, as well as our listeners, really can feel comfortable having a general framework using existing guidelines to approach the diagnosis and initial management in the patient we are seeing with COPD, as well as some practical advice from the both of you. Before we end, though, I'd like to leave our learners with some final takeaway points. Dave, what about you? What's one thing you want our learners to remember from our discussion today?
Yeah, I have like too many. I could just repeat this whole hour, but I think the big ones, I liked what Seam said, 20% of people may have no smoking history or not a significant smoking history. And so to keep it on the differential and ask some other questions. And then Bob was talking about things on the PFTs and especially the lung volumes. I like that correlation that with total lung capacity, we were really thinking about emphysema. And then for the RV or RV over TLC, we're thinking about the gas trapping and small airways disease. So I'm going to keep those pearls with me.
Bob, what about you?
Well, I think the key things are, first of all, the importance of spirometry in making the diagnosis of COPD. About 25% of the patients who are diagnosed and treated for COPD have perfectly normal lung function. We don't know what to do with those people. Some people call them gold zero. Some people call them a non-obstructive chronic bronchitis. That's a common condition, so spirometry is really central. The other thing that I want to emphasize is the importance of either self-directed exercise or rehab. It's probably one of the most important things we can do, better than any medication in terms of improving quality of life, preventing hospitalization, and now, according to Peter Lindauer's paper, reducing mortality in COPD. So it's a big deal, and it's probably the biggest gap we have in our treatment of COPD patients.
That's awesome. Thanks, Bob. And Wasim, what about you? One point you'd like learners to remember?
Yeah, I would like to say the basics are really important when it comes to COPD diagnosis and management. The importance of spirometry for COPD diagnosis, as Bob was saying. But in terms of treatment, again, inhaler therapy is the backbone of COPD therapy, and before thinking about advanced therapies, such as azithromycin or roflumilast or some interventional therapies or lung transplant, you have to get the basics right, because sometimes, medications keep getting added, to patients, whether it is in the context of hospitalizations or multiple outpatient visits, and eventually these patients get referred for more advanced therapies. But when you sit down, and try to understand what's happening with the patient, sometimes you find out that the patient does not know how to use their inhaler because they were never taught, or they were never on the appropriate inhaler therapy given their COPD severity, or they have not been able to consistently afford their inhalers and therefore have not been able to adhere to them for that reason. But then medications keep being added on, and therefore it's important to go back to the basics, make sure you have those squared. And again, smoking cessation, pulmonary rehab, adequate inhaler therapy, and see how the patients fare on these initial therapies, and then build from there.
And Wassim, we may have to have you back on. I have this dream of having a video Poem Peeps episode where we have like all the different inhalers and we just teach people how to use each of them, because I feel like, that inhaler technique is so important. Before we end today, Monty and I are extremely excited and honored to be having this partnership with the ATS Clinical Problems Assembly. And we know you both have played roles there and have been members of the CP Assembly. So we just wanted to have a minute or two where you could talk about just some memorable activities you've done there, or activities going on that people get involved with, just so our listeners can learn a little bit more about it.
One of my favorite things to do is getting involved in the Clinical Problems Assembly, just to serve the mission of the Assembly and the ATS as a whole. So over the last few years, I've been involved in the Program Committee, in the Apprenticeship Committee, and in the Journal Club Webinar Committee. And these have been great ways for me to get involved in ATS, work with other people, learn from other people, and it has been a great experience. And for our listeners, really quickly, the Program Committee is tasked with reviewing and rating abstracts for the conference, and helping come up with sessions for the conference. The Apprenticeship Committee looks at applicants who are interested in eventually learning under a mentor and eventually joining the Program Committee or the Planning Committee. And the Apprenticeship Committee is under the Early Career Working Group, which I certainly encourage all fellows and junior faculty to get involved in. And the Journal Club Webinar Committee is, a group of us leading a Journal Club webinar every, 3 to 4 months, within the Clinical Problems Assembly. It has all been great. It has all been very rewarding to me, and I just enjoy all the collaborations I get to have from these activities.
Well, Wassim really has contributed so much, deserves the thanks of all of us who are on the clinical problems. But I think that the way that people can contribute a lot is simply by participation in the symposia and the scientific sessions, and that can occur at any level. Proposing a symposia is a great thing to do, particularly for young faculty. I still remember very well the very first poster and first 10-minute talk that I gave at the ATS International meeting, and these are great things for our young trainees to participate in. So there's a lot to do. I think the Clinical Problems Assembly is really the largest and really the heart of the ATS.
Fantastic. Well, thank you both so much for coming on. We really, really appreciate it, and we hope to continue these great discussions. This episode was produced, recorded, and edited by myself and Christina Montemayor, and the music was original music made by Eric Rogers.